we should get started. I want to say welcome to this year's MS Capstone presentations. This is the second cohort of students in the Department of Biostatistics MS Capstone program. Before we start today's presentations, I want to give a huge shout out to all the sponsors of our Capstone students for your immense support and time you've given the students over the past 6 months, and for giving them a real life experience of what it is to be a biostatistician. The biostatistical struggles and triumphs the students have had over the last 6 months will be invaluable to them in their future careers. Well, we have a wonderful and full program today. Over the next 2 hours, you will hear from 5 different projects and from 18 different students. Each group will present for about 20 minutes. Then the sponsors that are attending will have a few minutes to say whatever they would like to. And then we should have time for question and answers at the end of each presentation. At that time, Min will open up the Q&A feature in Zoom. So if you have a question, just unmute yourself and ask a question. Ming will also be keeping us on schedule, so we'll try to finish as close as possible to 6:15. And without further ado, let's hear from our first group. You're up, Project 1.
Lloyd, could you open the screen sharing feature?
Is that something I can do, or Ming, can you do that?
I'll do it right now. Was that Quinn? Is that you that asked for it?
Yeah.
Okay.
I will go ahead and start. So good afternoon, everyone, and thank you for your time listening to our Capstone project presentation. Our project is evaluation of EPIC predictive analytic models using UW Medicine EHR data. There are 4 team members in our project team: Yu Jia, Qing, Jiawen, which is me, and Ling Bo. First of all, we want to say thank you to our sponsor, Sean and UW Medicine, and also Jim Trevor team for their great help for our project. Also, Capstone project instructors Patrick and Lloyd for their great time and effort. I will start with some background for our project. The data set we use, one of them is the EPIC electronic health record system data. The benefit of this system is they use common data model to make it more convenient for countrywide health providers. There are also many drawbacks for this system. For example, the data is kind of messy. There are many dictionaries of data in there. And nowadays, machine learning gets more and more popular in healthcare and other healthcare related systems. The machine learning data models in UW Medicine currently, for example, there are real-time prediction of sepsis and also no-show prediction, which is also our main focus in our project. However, peer-reviewed research also find disparity in machine learning predictions. There are evidence of underperformance in women, ethnic, racial minority subpopulations. And the major motivation for our project is an analyze for EPIC subset model. The EPIC subset model is a widely adopted prediction model already used by hundreds of US hospitals. However, although the AUC report by EPIC is as high as 0.76 to 0.83, when it's tested on a outside data set, which is University of Michigan's healthcare data set, the AUC is only 0.63. So we want to test how the EPIC no-show prediction models will performance on UW healthcare data. And this leads to our first goal, which is evaluate model performance. And as I said previously, since there is evidence of underperformance on some specific subpopulations, we also want to see how the model perform on different subgroup of patients. And also we want to build alternative models to see if we can have better performance.
An overview of the data we have for the whole data set. So the whole data set has over 12 million appointments. And data are from 2018 to 2022. With this data set, the no-show rate is around 6.8. For the further evaluation and model building, we are gonna only focus on completed and no-show appointments. So we're gonna drop all of the other appointments. This is the subset we use for evaluation purpose. In this data set, it has 700,000 appointments, and the no-show rate here is 7.3%. The outcome of the EPIC no-show prediction model is a prediction score, which range from 0 to 100. As we said before, we only consider complete and no-show appointments. And those data are from January 2020 to January 2022. Next, we're gonna present a EPIC predictive score distribution, and also we're gonna evaluate multiple performance use AUC. We're also gonna evaluate on subgroups by race, ethnicity, gender, and institution, and similar performance on similar features for the PR curve. So first of all, this is the score distribution of the EPIC score. If the score is close to 0, the appointment is likely to be show. And if the score is close to 100, it's more likely to be no show. As we can see, the distribution is clearly right skewed because the majority of the appointments are completed the most appointments are shown. So it's right skewed. The next slide, the next picture is the RC curve for this whole data set. The AOC of this is 0.73 with 95% confidence interval of 0.73 to 0.74. With our AOC is 0.73, the AOC reported by EPIC on their data set is 0.83 on their site 1 data and 0.87 on their site 2 data. So the AOC again is worse than they reported as the sepsis model like the Michigan did. Next, gonna see some model performance in some subgroups. For the race one, the model performance are in white groups outperform the other groups. So the AOC in white group is 0.74, with other is around 7.7. And for the ethnicity, the non-Hispanic or Latino group outperformed the Hispanic or Latino group based on the confidence interval. And also we look into gender. So the male group are performed better. The model performance in males are better than in females. And the performance in Utah Medical Center is a little bit better than the Harborview Medical Center. I think our results kind of agree, our findings agree with the previous evidence that the EPIC model kind of have worse performance on some minority groups. I'm gonna hand it over to Jalvin to talk about some PR curve.
Thank you, Qing, for for the ROC curve. And as we know, we have an imbalanced data set, and that's why we also want to have precision recall curve, since the false positive rate using ROC tends to be small for imbalanced data set with large number of negatives, which is a complete case in our project. And here is the overall PR curve for the whole data set. And from this, we can see at 50% record, the position is around 27%. And also we divide our data set by year and have two different PR curves. And there is actually a year-wise difference in model performance. And here we provide the table of positions at 50% sensitivities. The performance is better in year 2020, since the no-show rate is actually higher in 2020. And this is true for both UW medical data and the EPIC model, EPIC healthcare data. Next, as what we do for AUC, we also did the precision record curve for different subgroup of populations. And generally speaking, the overall trend is, yes, the performance is different for different subgroup of populations. And specifically, if we see the race PR curve, the blue line, which is for Black population, and as they have a larger no-show rate, their line is the top of all these race groups. And next, I will let Yuja take over to the alternative model building part.
Thank you both for the introducing the evaluation for the model performances. So after evaluation for prediction based on the EPIC model, we now turn to our second objective to build our own models to see whether we'd be able to compete with the EPIC model. So firstly, we will talk about the feature selection for our model building. So there are three main categories, like patient information, appointment characteristics, patient appointment history that we would use for our model building. So it actually includes almost all the features used in EPIC model. And we also include additional variables, which was highlighted in dark red here. So for example, the BMI, height, weight, and as well as the race, ethnicity, and sex variables, because they were not used in EPIC model because of like some privacy issues. So currently, we are fortunate to include them to build our own models. So after retrieving the data and some data cleaning procedures, we performed some data processing before we like really going to like build our own model. So we split data into three parts: 60% to training set, 30% to test set, and 10% to be a validation set, which is kept it by UW Medicine. And we also did some featureization to cluster some of those variables with too many categories. For example, here, we clustered the 150 languages into three categories, like English, non-English, and the sign language. So basically, in our previous analysis that we do include over 92% visits like of those patients only used English as their language. And for the specialty, we have around like 145 specialty in total. As sometimes actually across different institutions, they use different wording for the same department, like standing for the same specialty. So we actually use that trick to cluster them into 24 different specialties. So after the featureization, we also did imputation for our missing values. So they're actually like, I will not say a lot, but a fair number of missing values in our EHR data. So here we just employed a simple method called the MICE, which is stands for the multiple imputation by chain equation. So basically, it assumes that our missing data is missing at random. And after the imputation, we just use one-hot encoding for those variables. So now we turn to our models. So basically, we employed 3 different models, complement, naive Bayes, a random forest. So naive Bayes was used by Epic as their first version of no-show prediction model, and random forest is the second version of Epic model. And we also here adding gradient boosting as our third model. We employed a five-fold cross-validation when we train model, and here just listed some setups, like what is kind of hyperparameters we choose for these 3 different models. And we also listed some pros and cons of these 3 different models. As you can see here, that for complement naive Bayes and gradient boosting method, they are both good for like imbalanced data. And for random forest, it's kind of tolerant to the changing the number of attributes that we use in model. And also there's some drawbacks of these models. So the naive Bayes, basically it's based on minimal assumption, but it does not really do well in the prediction performance. For random forest, it's quite computationally expensive. It takes a long time to train a model. And for the gradient boosting, that's a little bit hard to tune the hyperparameters.
Okay, so here are some results of our models, and we evaluate the model performances using accuracy, AUC, and runtime for 5-fold cross-validation. And the time are just given on just 1-fold cross-validation in terms of minutes. And we observed that the complement naive Bayes have uniformly relatively worse performances, but only take half minutes to run 1-fold. And we also observed that the random forest and gradient boosting methods are comparably good in performance by having almost 90% accuracy and about 0.8 AUC. However, the runtime of the random forest is about 20 times worse than the gradient boosting methods. And we also evaluate the feature importance, and looking at the dark color blocks, we can identify the Hasmedicant, institution, lead time, specialty, total cancel, total complete, and total no-shows as the top 10 features in 2 or more of our models. And we also listed the top 10 features identified by each model, and I will leave the audience to look into the details. So if you go to the next slide. And there could be some extensions after this study to improve the model performances. One is to add more relevant features like clinical or medical conditions. And the other one is to do parameterizations by extend our parameter space for more model tuning process. And lastly, we can analyze supergroup performances in those alternative models. And to summarize, we have 2 parts in our study. The first part is to evaluate the model performance, and we observed that the reality results are worse than the Epic reported results. In terms of the AUC decrease about 0.1, and the precision decreased about 10% at 50% sensitivity in 2021. And the second part of our study, we build alternative models, and we observed that the random forest and gradient boosting have similar good performances by increased AUC to by about 0.08, and also that the gradient boosting methods is good in computational time. And lastly, we identified 7 high importance features. And that's the end of our presentation. Thank you.
So Ming, I don't see their sponsor. I think Sean wasn't able to attend today from some of the commitments. So I think we can go to Q&A.
Yep, that's correct. If you guys could unshare your screen, that will help us see who is asking questions.
Yeah, please go ahead. Whoever have the question.
I can ask a question.
Sure, yeah.
Yeah, I'm curious if you have thoughts. So if I saw correctly, you use multiple imputation around missing data. So is the vision there that, like, if a model were adopted, that there wouldn't be any more missing data in the future? I guess, you know, like there's a school of thought that says if you're doing prediction and some data are missing, you know, sometimes there's information in the missingness, and missing should be allowed to predict versus, you know, maybe imagining a future where there are no missing data and you'll assume you'll have complete data when you try to predict. Did your group think about that?
Yeah, I think we have thought about that, but it seems like just based on like technical problems, like we need to like impute those missing data firstly, before or really training our models. And I think I were not really expecting that future data set will have no missing data. Because from our observation, like for each of the variables that we will have like probably like 10 to 20% of missing, according to different visits. So that's, I would say that's a tough question to solve. Yeah. Well, I would also appreciate if anybody have any idea about this.
Suzanne, do you want to unmute yourself and ask a question?
Yeah, unless somebody else wanted to comment on or answer the question that Julia said. If not, that's totally fine. I was wondering, the very first graph, it had a really, really interesting shape, and I might have missed it, but do you have any intuition besides that? It was the precision recall, I believe. Can you bring that back up?
Can I share the screen again? I'm not able to share the screen now.
Lloyd, can you help?
Ming might be able to do it, but because I don't see where the share thing is.
Then Min, can you help?
I can share it now.
Great. Yeah, those. They seem to be having a lot of data on the left end, and then what's going on that long tail? Is there any intuition regarding this? And taking the 50 percentile, I think, was another question that I had regarding these plots. It's where it's 50%. There seemed to be a lot going on there as well. Was that a good choice?
So first of all, for the intuition of the long tail, and I guess the answer is sorry, I don't really have much intuition on that, since this is a kind of a black box model provided by Epic, and I don't really know like what they actually did for the model. And for the 50% sensitivities, the answer for our choice for this threshold is that since Epic did evaluate their model, and the results they provide is a position on the 50% sensitivity, and to compare with Epic model, we also choose to report our positions on this sensitivity.
Okay, thank you.
Thank you for your questions.
Adam, do you have a question?
Sure, yeah. First, thank you for the great presentation. I was curious if you knew whether or not Epic's model was, if they used cross-validation for their model, and then if they did, why do you think that your model didn't suffer from the same like out of sample decrease in performance?
I think as we said that the EPIC model is actually a black box. We only know that how many, like what kind of features they were in and the outcomes. But I think at least for the model we build, cross-validation could be like a good practice to prevent overfitting. And that's the reason that we do cross-validation here.
Okay, great. Thank you.
We have time for one last question if anybody has a question or comment. Lloyd, you've got the floor.
Oh, okay. Well, I think we can go on then to our next project. Project 2, do you want to get started?
Yeah, I can share my screen now.
Yeah, sorry, for some reason I'm not seeing the share screen control. So Ming, you're gonna have to help me out here.
I think it's working for me, so
Cool.
just let it load for a sec. Okay.
Awesome. We'll get started. Hi, everyone. We're presenting our capstone project on the Housing and Urban Development Health and Environmental Residential Stability Study, or the HUD HERE study. So my name is Nikki. My team members are Hantong, Taylor, and Zichen, and we worked alongside Danny and Alistair from Public Health Seattle King County. And Hantong will take it away with the background.
Okay, so a little about the background. As you all know, housing is a very important social determinant of health, but there are people who are sometimes not fortunate enough to pay for housing on their own, so they turn to affordable housing. However, affordable housing is a very limited resource, so it is better and more sustainable to help people exit from affordable housing rather than keeping them in the housing as long as possible. And that's what the United States Department of Housing and Urban Development wants to achieve. And that's also why we're studying about public housing exits. So before we started our study, we identified some problems. That is, their existing literature is very sparse in first, defining positive and negative exits. Second, exploring factors associated with positive and negative exits. And third, examining long-term outcomes from different positive and negative exits. So luckily, our sponsors help us explore the first two problems. So in our project, we're only going to focus on the third problem. And that brings us to our primary objective. Our primary objective is to determine if there's an association between positive and negative exit types and long-term outcomes. For long-term outcomes, we're only focusing on housing outcome, which is defined as time to experiencing homelessness within 1 year of exit. Next, Zichen will talk about our study population.
Thank you so much, Hantong.
Sorry, can I ask what a positive versus a negative exit is? Or are you going to define?
This is actually when you exit from the public housing, you're going to not possibly the participant, but the official will file a kind of form that states why you leave the housing. And that is called the exit reason. And the exit reason is then divided into 3 categories, the positive, neutral, and negative. And for example, a positive can be you have enough income, so you left the housing. And an example for negative housing, negative exit is probably you're evicted by the landlord. So this is based on more of an intuition thing.
Okay, awesome. Thank you so much.
Mhm.
Okay, so now I'm going to describe our study population. So we're interested in anyone who exited the following public housing authorities: Seattle Housing Authority or King County Housing Authority, which are mutually exclusive. For SHA, we capture those who exited from 2012 to 2019, and for KCHA, we capture those who exited from 2016 to 2019. And this is because the exit reasons for KCHA are incomplete before 2016, so we couldn't use the earlier years in our analysis. There is another public housing authority, which is Renton Housing Authority, but since there's a lack of a data sharing agreement with them, we weren't able to include them in our analysis. So within SHA and KCHA, we're interested in tenants who receive one of two federal housing assistance types, either a hard unit, which means that the subsidy is tied to the housing unit itself, or a soft unit, which means the subsidy is tied to the tenant who gets a housing choice voucher. We're excluding those who get other types of housing assistance types, for example, permanent supportive housing, since our goal is to evaluate exit types. Okay, so we use several different data sources that are linked together. Our main source of public housing data comes from this HUD form. It collects information on individual and household characteristics, housing status, and also entrance and exit dates to and from public housing. For our homelessness outcome, we use several different data sets that can indicate if someone seeking services or care from each of these sources is homeless. It's really hard not to undercount homelessness, so we try to combine these 4 different data sources in hopes of casting a wider net. So if anyone appears to be flagged as homeless according to any of these data sources, they count as experiencing a homelessness event. And finally, we use the Puget Sound Regional Council opportunity mapping to provide a variable describing neighborhood quality, and I'll talk more about this variable on the next slide. So here's a summary of all the variables we use in our analysis. As you can see, they're either at the individual household or neighborhood levels, and by neighborhood, I mean census tract. At the individual level, we have some demographics variables that we use as individual level covariates, such as age, gender, and race and ethnicity. And also we have the time to homelessness outcome variable. At the household level, we have household covariates, such as which public housing authority they used, SHA or KCHA, the program type, so these are the hard or soft units, the household composition, so like household size, whether the household has a single caregiver, whether the head of household has a disability, and also the time spent in housing before exiting. And also we have our exit type variable here, which is our predictor of interest. And this is collected at the household level because the HUD form is filled out on a household level. At the neighborhood or census tract level, we use opportunity area index, which is the variable I mentioned on the previous slide. It basically captures if a census tract is opportunity rich or opportunity poor or somewhere in between. And this index is determined by a variety of different factors, such as economic health, education attainment, and also housing and transportation quality of our neighborhood. And just to note, because some people in our data come from the same household, we account for clustering by household ID, but Nikki will talk more about clustering later. Finally, I wanted to help clarify that the formal definition we're using for our outcome of interest is days to the first instance of homelessness within the first year of exiting public housing. So hopefully this makes sense. It's a time to event variable, and for each person, we're only interested in their first occurrence of homelessness after they exit from public housing. But we decided to implement a 30-day buffer to this because sometimes there's a little bit of administrative lag between when somebody actually exits and the date of their exit on file. So anyone who becomes homeless up to a month before their exit date is still included in our analysis. Another thing is that we only look at homelessness within the first year because with time to event data, we lose people to follow up over time. So for example, if somebody left King County and we didn't know about that, we have no way of finding out if they actually became homeless or not. So right now we're assuming that anybody who doesn't appear as homeless isn't homeless, and this assumption gets worse and worse over time. So we decided to restrict our analysis to a shorter time period and only focus on homelessness within 1 year. And now I'll turn it back over to Hantong.
Okay, thank you, Zichen, for explaining the variables. So after we have our data ready, we first had an overview of the data and found that, first of all, our sample size is 17,224. And each person has exactly one exit. And among these people, we have 2,794, which is 16%. They experience homelessness within 1 year of exit. We also did a little exploration about our data quality, and we found that the opportunity score variable has 3% missing, and for all other variables, they're less than 2% missing. Due to this very small percentages, we think our data has a very good quality. And next we have this Kaplan-Meier curves. This curve is basically telling us that if we only look at the exit types and the outcomes, we have 3 distinct non-overlapping curves with positive the flattest and negative the steepest. We also found out that the largest drop is from 0 to 50 days. Note that there's a almost vertical drop at day 0. That is because, as Zichen just mentioned, there are people reported homeless up to 30 days before exiting, and these people are said to have an event at day 0. We also found out that the probability of remaining in house at 1 year after exit is for positive exit, 97%, for neutral exit, 85%, and for negative exit, 75%.
So in addition to that, we wanted to explore the relationship between exit type and time to homelessness, taking into consideration potential confounding. And how we went about doing this can be split up into 3 steps. So in step 1, we derive our propensity scores, and propensity scores are a great way to take into consideration confounding in the setting of using observational data. So what is a propensity score? A propensity score can be thought of as someone's propensity for or probability of experiencing some event of interest. And for us, that event of interest is exit type from public housing, where we have positive exits, negative exits, and neutral exits. So note that this is not a binary variable, and so we decided to fit a multinomial logistic regression model where we're also using GEE and clustering by household. And we're doing this because, as Zichen mentioned, we know that we have household clusters in our data, and we want to take that into consideration in our modeling. So then in this model, the predictors that we're including are those confounding variables that Zichen had mentioned previously, and the outcome is exit type. And from this, what we get is that for each observation, there is a propensity score for a positive exit, a propensity score for a negative exit, and a propensity score for a neutral exit. So then we take all these scores and we take them into step 2, where we're calculating the weight for each observation. And we're doing this via inverse probability treatment weighting. So what this means is that from step 1, right, we had these propensity scores for positive, negative, and neutral exits per observation. But let's say someone in reality actually experienced a negative exit from public housing, then their weight would be equal to 1 over their propensity score for a negative exit. So then we use these weights in step 2 and we pass them into our Cox proportional hazard model in step 3, where the predictor of interest is exit type and the outcome is time to homelessness. And note here that the baseline we're using for comparison is neutral exit and our outcome is time to homelessness. And we're also clustering by household here using a sandwich estimator so that we can get robust standard errors. So then that takes us to our results. So on the top left in blue, we see that the hazard ratio comparing positive exits to neutral is approximately 0.19. And what this tells us is that at any point within the first year post-exit, those with positive exits are approximately 81% less likely to experience homelessness compared to those with neutral exits. And then in the bottom right in red, we see that the hazard ratio comparing negative exits to neutral is approximately 1.87. And this tells us that at any point within the first year post-exit, those with negative exits are approximately 87% more likely to experience homelessness compared to those with neutral exits. And so here we see a really distinct difference comparing those with positive exits to those with neutral exits and comparing those with negative exits to those with neutral exits.
So after our primary analysis, we wanted to conduct a sensitivity analysis that was looking at exit reasons. And so the motivation behind this is that our predictor of interest being exit type here is very complex. So administratively, whenever someone leaves public housing, they're assigned an exit reason. But there's 82 of these exit reasons between Seattle Housing Authority and King County Housing Authority. And then these exit reasons are grouped into the 3 categories: positive, negative, and neutral. So what we want to determine is which of these exit reasons are the most influential in the analysis, and whether our conclusions are robust to any specific exit reason classification. So we perform a leave one out on the exit reasons, where we take each exit reason in turn, remove it from the sample, and rerun the analysis. And we do this for all exit reasons that had over 100 observations in the sample. So this produces this forest plot on the left for the comparison between negative and neutral exits. So on the x-axis, we have the hazard ratio of experiencing homelessness. The bottom row corresponds to the estimate and confidence interval from the full data. And then each row above that corresponds to the new estimate and confidence interval if a specific exit reason was omitted, the number of observations omitted, and the exit category for that reason. So in terms of interpretation, we first want to emphasize that there's a lot of noise in these estimates due to reweighting the observations each time we're removing an exit reason. So we don't want to be over-interpreting small changes in the estimates and confidence intervals. However, in general, a lower hazard ratio estimate is closer to 1 here, and so leads to negative and neutral exits being more similar, and a higher hazard ratio estimate leads to negative and neutral exits being less similar. So overall, the results here support our conclusions from the primary analysis that Nikki went over. But 2 observations that stand out to us, the first being landlord evictions. So when landlord evictions are removed, the hazard ratio decreases. And so negative and neutral exits become more similar. And this leads us to believe that landlord evictions are the most negative and the most influential of these negative exit reasons. And so that's a really important finding for us. Secondly, if we look up at the top row, this is project-based, moved out, location unknown. When this neutral exit reason is omitted, the hazard ratio increases greatly, and negative and neutral exits become even less similar. And so this leads us to believe that this neutral exit is the most negative of the neutrals and potentially more similar to a negative exit in nature than the other neutral exits. We can do the same process in our positive versus neutral exit comparison. Note here now that the x-axis scale is below 1 for the hazard ratios. So now a lower hazard ratio estimate leads to positive and neutral exits being less similar, and a higher estimate leads to positive and neutral exits being more similar. So again, overall, the results support the conclusions from the primary analysis. However, 2 observations that stick out to us is this move to non-subsidized rental in the positive exits. So when this is removed, the hazard ratio decreases and positive and neutral exits become less similar. And so this means that this is the least positive of these positive exits compared to, for instance, the next 2 rows, over income and home ownership, which seem to be more positive in nature. However, this move to non-subsidized rental is a large portion of the positive exits. There's about 3,000 positive exits total. And so the width of the confidence interval, the resulting confidence interval, is very wide when this is removed. So we don't want to be over-interpreting this too much. But if we go back up to the top row, project-based moved out, location unknown, we see that the hazard ratio increases when this is removed. And so neutral and positive exits become more similar. And this gives us even further evidence that this neutral exit is the most negative of our neutral exits. So wrapping all this up, even though we've shown that there's an association between exit type and the hazard of experiencing homelessness, the population of individuals within a specific exit type have different reasons for exiting public housing and have different outcomes post-exit. And so this motivates for us further study into the look into specific exit reasons.
Awesome. So that brings us into our conclusions and next steps. So the broad takeaway of what we've shown here is that positive exits are generally associated with a lower probability of experiencing homelessness, at least within that first year post-exit. Additionally, negative exits are generally associated with a higher probability of experiencing homelessness, again, at least within that first year post-exit. So then what's the impact of all of that? Well, since how someone exits from public housing has been shown to be associated with housing stability, this is further evidence for public housing authorities to allocate their resources in order to help people achieve, in particular, positive exits and to avoid negative exits from public housing. So then a couple of next steps we've identified. First, we thought it'd be interesting to investigate some other long-term outcomes, such as change in income. So for example, comparing someone's income at time of exit to their income 1 year post-exit. Additionally, kind of adding on to that sensitivity analysis that Taylor had explained, we thought it would be interesting to look at the impact of specific exit reasons on long-term outcomes. So adding on to just these 3 buckets of positive, negative, and neutral that we have, how does one particular exit reason, say landlord eviction, impact someone's time to experiencing homelessness? So finally, we just want to say a big thank you to all these amazing people who helped us out along the way. And thanks for listening. Does anyone have any questions?
Well, I think before we get to questions, let's your sponsors, Danny and Alistar, are here. So if you'd like to say a few words about your group, we'd love to hear from you.
Sure. This is Danny Columbara. You know, this group has been a joy from the beginning to end, from the very first day that we've met until now. I think one thing that I feel like I missed out is the face-to-face time, which obviously we couldn't make anything better because of the pandemic, but very appreciative of their hard work, perseverance. We had one big portion of our data set fall through, like found out midway they weren't going to have access to it, and they just kept rolling with the punches. So very, very appreciative of all of their investments. Only disappointment is that none of them has shown interest in coming to work with us at Public Health. So aside from that, I couldn't have asked for more. Thank you so much.
Yeah, I'm just going to echo what Danny said. It's been a great group to work with, and they've been very adaptive to the inevitable real-world data problems that exist. They navigated the bureaucracy of local government successfully, and came out with really a great product that I can tell you the housing authorities that we work with are super excited about these findings. They're really jazzed to get this sort of data. It's kind of first in the country kind of stuff that would, so HUD's very excited as well. So I think there's going to be a lot of interest in these findings going forward.
Great, thank you. Now we open it up to everybody. If you want, anybody that wants to ask a question, just unmute yourself, or I should say, right, raise your hand and Ming will unmute you.
Adam, do you want to ask your question?
Sure. I feel like I'm hogging the question, so if anyone else wants, feel free to jump in. I was curious if you studied the differences between the 2 types of housing assistantship, both kind of at like a categorical level, but also at like in a cost effectiveness framework. This is a kind of out of left field, so fine if you didn't. And this is like the difference, sorry, between a voucher program and then like hard housing.
Yeah, unfortunately, because we use propensity scores, we couldn't evaluate the effects of that specific covariate, but we recently were able to produce separate results for SHA and KCHA, like a separate analysis for both of those. So that's definitely something we could do like fairly easily in the future, but we just haven't done that yet.
Okay, cool. Yeah, no, that's very cool.
Any additional questions? Nina?
Yeah, sorry if I missed this. I was wondering what kind of variable you were adjusting for in your propensity score models.
Could we maybe go back to the variable slide? Yeah, so we're just basically like age, gender, race, ethnicity, and then all the household level covariates and the opportunity area index. Basically all the variables not in bold are covariates that were that are used to calculate our propensity scores.
Thank you.
Well, I don't have a question, but could you guys just briefly discuss what you did a couple weeks ago? You had a special meeting. It was not with your sponsors. Would you like to share that? Alistar mentioned it, but I don't know if people caught it.
Sure, I can briefly explain. So in addition to Danny and Alistair from Public Health Seattle King County, we've also had some Public Housing Authority folks that have helped us out along the way. So kind of explaining the opportunity area index variable, providing some insight on how public housing actually works, like the nitty gritty of it, including the administrative data aspect of things. So kind of throughout the steps of this project, we've been presenting to them our findings and kind of getting feedback from them. So most recently in our meeting with them, they seemed super excited about the results we got, which was really great. And it seems like we'll be presenting to a broader audience sometime next week or the week after that. Time is kind of blending together, but yeah, so super exciting to be sharing our results with a broader audience coming up.
Great, thank you.
I have a quick question. That's okay. Just one. Okay. Yeah, no, it seems like you all had really exciting results and like very interesting. I was kind of curious about like the exit reasons. They seem like they're kind of the most actionable things for like these public housing associations. What were their like intuitions on your sensitivity analyses? Did it kind of seem consistent with what they were expecting? Were they actually things that like are of interest and kind of actionable things that, you know, these people can really intervene on and stuff like that?
Yeah, I think that's a really good question. Yeah, and I agree. Like this is kind of where they can actually try to allocate, like tailor their resources into specific programs, like specifically like landlord evictions, like, you know, violation of lease rules and things like that. Like, can they create programs that help educate people, you know, their community about the rules so that they don't experience some of these negative exit reasons. So I think that is like what I see as some of the like actionable insights they can take from these findings. Obviously for the positive exits, it's a little bit more challenging. Like how do you make someone, you know, become over income? That's a little bit more challenging, but yeah, I think that's kind of, those are my thoughts, unless anyone else has any thoughts.
I think also adding on to answer the question about if any of this intuitively made sense. I think the exit reason at the top shown here, the moved out location unknown, how in both forest plots, it seems to show that this exit reason actually might be more negative than neutral, I think makes sense intuitively, because moving out location unknown could be the potential that they became homeless and were just lost to follow up. And since our outcome is time to experiencing homelessness, that kind of makes sense that this exit reason would actually be more negative in nature than neutral. But I also want to second everything that Taylor said too, with regards to the first question.
Great. Thank you, guys. I think it's time now for us to move on to project 3.
Okay. I will go ahead and present here. Okay, hey everyone. The name of our project is Applications of Nowcasting Methods to Notifiable Disease Surveillance, and our disease of interest here is COVID-19. Quick overview of our team. Our sponsor is Ian Painter from the Washington State Department of Health, and the students on our team are myself, Ben, Yangja, and Fred. Some quick background on our problem. So the Washington State DOH is concerned with COVID-19 hospitalizations, among other metrics. In order to track the spread of the disease, they would like to associate hospitalizations with the date of disease transmission. And while this can be somewhat tricky, they equate positive test collection date as the date of disease transmission for the purpose of this tracking. And so here you can see a graph from the DOH website with hospitalizations by date. And there is some uncertainty in the most recent days, denoted by gray bars here. And we'll talk about why there is that uncertainty. So our problem focuses around one key delay of interest, and that is the delay between when someone tests positive for COVID-19 and when their hospitalization is reported. Now, there's a fair amount of variability in this delay. So if you were to think about the life cycle of the disease, let's say a patient gets infected on day 0, a couple days later, they exhibit some symptoms. Maybe they'll get tested at this time, or maybe due to lack of testing or lack of severity with the symptoms, they'll get tested a little bit later. Now, in our data, the latest time at which someone will test positive is the date that they are admitted to the hospital as part of standard hospital admission processes. When you are admitted, you get tested. And then after someone is hospitalized, the hospitalization will be reported, and that's when it shows up in the DOH system. So a couple of examples here to build some intuition. Subject 1 tests positive on day 1, so they get their test done pretty early. They're hospitalized. Their hospitalization is reported on day 10, so this would be a delay of 9 days. Subject 2, on the other hand, waits a little bit longer to get tested. They have a positive test on day 9. Their hospitalization is reported on day 11, so this would be a case of a 2-day delay. So our objectives as part of this analysis are to understand the nature of the data and the delays, develop nowcasting models to mitigate their impact, and evaluate these candidate models in order to determine which is the highest performing option. Following that, we want to work with the DOH to establish the context under which the model may be utilized by them moving forward. So I'm going to give some quick background to help build some intuition around how nowcasting works. So the idea behind nowcasting is to estimate the occurred but not yet reported events. In our case, some of these might actually have yet to occur, but it's the idea that you are associating things to a date in the past, as in how many hospitalizations are going to result from people who test positive in recent past, as in maybe yesterday. So this idea originated in actuarial literature, but it found applications in public health when analyzing the HIV/AIDS epidemic due to the latency of that disease. And one of the critical features here is modeling the delay distribution, and we'll talk about that a little bit further. So we're going to walk through a toy example here to explain how this works. So on the y-axis here, you have the time of a positive test, and on the x, you'll have the delay in hospitalization reporting. So on day 1 here, you have only one piece of information, which is basically the number of people who had a positive test on this day and were reported with no delay. Fast forward 1 day. On day 2, you have the number of people who tested positive at t=1 or day 2 and were reported with no delay. But you also have an additional piece of information about time t=0. You have the number of hospitalizations that were reported with 1 day of delay there. And so as you can imagine, we'll continue to build this sort of stair step, and we'll on day 3 have an additional piece of information about those who test positive on t=2 and were reported with no delay. And then now we have 3 pieces of information about time t=0. And we'll keep going through this until eventually we hit what is known as the maximum delay of interest, denoted by capital D in this case. So for the purpose of this example, capital D is equal to 5. What this means is we're only interested in hospitalizations that occur with a delay up to day 5, and we are not concerned with hospitalizations that occur after this. So to get the total amount of hospitalizations attributed to a certain day, you'll take the row sum across all the cells, and that'll give you the total count for hospitalizations. If you were to get the total count for time t=1 in this case, you would have to perform an estimate for one of the missing pieces of information, and so on and so forth. You need to estimate more and more information as you approach the more recent timeframes. And so that estimation process is the goal of nowcasting. So coming up with these estimates so that we can obtain the totals for each day is our goal in this process. So one other thing to highlight is that moving forward, let's say we fast forward 1 day from there. On day 6, the window simply shifts because we know all of the information that we care to know about time t=1, and the total number of days that we are now casting for does not change. So now I'm gonna pass it off to Yangja to talk about some nowcasting methods.
And now we are going to talk about the nowcasting method. And the general nowcasting framework we're using follow a Bayesian hierarchical model. The basic assumption of this model, we have to assume the small NTD, which represents for case counts at T, report the days of delay. And this small is just purple boxes in plot that we've seen before. And we assume that this amount will follow a underlying inhomogeneous Poisson process with the mean. And this mean can be decomposed into two parts. One part is the epi curve, another part is the delay distribution. In order to estimate the final amounts of the small n, we have to estimate the rate of occurrence of cases at day t, which is to estimate the epi curve, and then to estimate the portion of the case at day t delay for days, which we call delay distribution. And eventually we can use the SDA epi curve and delay distribution to make a prediction for observed SMAN-TD in order to compute the total number of cases of day t after days of a delay. And the small n here still is the purple box in the plot, and the larger n here, just the row sum of all purple boxes. And then we can go into the next page. And we eventually use two models to perform this task. The first model we refer to HH method. In this model, the epi curve will assume follow a gamma distribution, and then the true count given mean as a Poisson. And the delay distribution in here, we assume the delay is a time variant delay, and will be modeled by using the generalized Dirichlet multinomial conjugacy framework. And the another improvement version of the model is called a NUPS, which refers to nowcasting by Bayesian smoothing. In here, they model the epi curve with a first order random walk. Still in delay distribution, they assume a time varying cases and model the time varying cases with the generalized Dirichlet multinomial conjugacy framework. And then I can pass the next part to Ben and Fred for our exploratory analysis and results.
All right, thanks for that. So I'm going to run through some of the exploratory work that we did. So the input data you can think of as having one row per hospitalization. And as I described before, we're interested in the delta between test collection and hospitalization reporting. The date range of the data is from June 2020 to January of this year. And we worked with the Department of Health to identify the maximum delay of interest at capital D notion from before as 21 days. So basically we're concerned with hospitalizations that occur within 21 days of a positive test, and we are not as interested in those that occur after that. So based off of this max delay of interest and the date range of our data, we needed to start 21 days after the start of our data and 21 days before the end of it. So we're going to be considering information from June 2020 until late December of last year. And one thing that we wanted to look at was the delay distribution across all timeframes. And so this is, considering the full range of data, the proportion of hospitalizations that are reported with a certain day of delay. The number one thing to note here is that there are no hospitalizations, not a single record that is recorded on the same day as the positive test collection. That's just due to the inherent processing of information by hospitals and the department. So the first delay at which we start to see information is a delay of 1. The plurality of cases occur on with a 2-day delay. So over 20% occur with a 2-day delay. And then that proportion subsequently declines for each increasing amount of delay. One thing that we wanted to evaluate was whether or not our data actually exhibits a time homogeneous delay distribution, as in is the delay distribution the same across all time? One way that we sought to evaluate this was to look at the number of days needed to record 50% of hospitalizations. And so the basic idea here is if the delay distribution actually was the same over all time, you'd expect the graph to basically be a flat line. It would take the same amount of days to reach 50% of hospitalizations across the entire date range of interest. However, that is not what we see here. It actually tends to follow the epidemic curve or the volume of cases. And so basically when volume is high, cases are high, or sorry, but the amount of time that it takes us to hit 50% hospitalizations is high. And when volume is low, we correspondingly get to 50% of hospitalizations faster. And the data is incredibly noisy, so this is with a smoother applied, but it is interesting to consider some of the assumptions that were made in our modeling process. And so I'm going to hand it off to Fred to talk about the results of our nowcasting model.
Okay, thanks, Ben. So in the next few slides, we will give the example outputs from using the two models to perform a single time of nowcast on a given current date. On here, we make May 15, 2021 as example, and a time window of 31 days before the current date will be supplied into the two each model, assuming to perform the nowcast and with the 20 days of maximum delay assumed, as Ben just mentioned. And first, we show the partial count of hospitalization on the May 15, and on each of the 21 days prior, reported up to the current date, May 15. So these represent the information that are available to us on the current date, May 15. And then if we go to the next slide, we plot the full count of the hospitalization on these dates. These are the true hospitalization count and the gap as shown as in the dark blue solid lines. And the gaps between the two lines are tell us about the number of cases that haven't been reported, haven't been available to us until at least one day after May 15. And then if we define in the next slide, so-called the lookback time to be the days elapsed from the date of the case onset to the current date, then the length of the lookback time represents how many days of information we have collected about the hospitalization on that date. And we observe from the line graph below that at the case onset, date gets more recent, which corresponds to shorter lookback time. The gaps between the two solid lines increases since we get less information about the cases, about case counts that are more recent. And then we plot the estimates from the performing the nowcast using two models, and we added at the two dashed lines in this graph below, and we see also that as days get more recent, more unreported hospitalization cases need to be predicted. The performances of the both models get poorer for more recent case onset dates. And if we go to the next slide, we then evaluate the overall performance of the two models by performing nowcasts for each of the days in the date range we're interested, from July 2nd, 2020 to December 21st, 2021 at the current date. In total, 539 times of nowcasts were performed using each model, assuming 21 days of maximum delay. So for each time of nowcast, 21 plus 1, which is 22 nowcast estimates for each of those days will be produced for each now. And then we compute the relative mean error, the RMSE, as our main error metrics for evaluating their performances. The median of the 539 RMSEs are shown in the table below. And we see that overall, the knobs by spatial smoothing method perform a little bit better than the classic HH approach. And when only evaluating performances while at least 5 days, information are become known, which is like in the situation when we optimistically allow for 5 days to collect information and then prepare to accommodate for cases that are at least 5 days before. Then the nowcasting performance for both methods are very close through our evaluation approach in terms of the median RMSE. In the next slide, we plot RMSE as a function of the look-back days. And expectedly, we observe that the errors for both models decrease sharply as we get information, while the HH model perform slightly better under shorter period of look-back times. And in the next slide, through our collaboration with our sponsor, Ian, after we decide that knobs to be the winner among the 2 popular nowcasting methods we have examined, the crucial question our results can be used to address is how long shall we wait to achieve estimates that are accurate enough. So from this graph below, which shows the proportion of estimates with relative errors below within the relative error threshold determined to be 0.2, we observe that to have over 90% of the nowcasts with acceptable error within the acceptable error range, we would need until about 8 days information to become available to us to produce reliable nowcasts. This is satisfying as the current DOH practice excludes most recent 16 days. And by using the knobs model, decision-making process will be sped up by 8 days. So that will be all for the results we would like to show for this presentation. And I'll pass back to Ben to conclude our presentation for our project.
Okay, great. So the next steps for us are to hand off this model to the DOH. And as part of that, we want to determine the parameters of the use and establish some guidelines like what Fred just outlined around, when is it okay to use this model and when can it be used to make the decisions. We'll hand off the code and the guidelines and hopefully allow for the model to be utilized moving forward. As for improvements to the model, we would like to incorporate reporting hospital information, which is a dimension that we had yet to consider as part of either the regression or as to create a stratified model by hospital. And then also perform a version of the HH method with the epidemic curve modeled by spline. This particular method actually doesn't assume time and varying delay distributions and would accommodate some fluctuations there, but it was not executed as part of our analysis due to computational infeasibility. So just wanted to give a special shout out to our sponsor Ian and Professors Patrick and Lloyd for your help in this process, and to all of our fellow classmates for your guidance along the way. And we'll take your questions now, or maybe we'll send it over to Ian for a quick comment.
Yeah, let's go to Ian first.
Okay, yeah, thank you. This has been, for me, a really fun project, and I've really enjoyed the collaboration process. I think it's a pretty tricky problem to be given because it's doesn't fit into the normal framework, I think, of what you learn about in statistics and biostatistics. And so it really had to delve into the both the theory and the kind of practical side of the method. So I think it's done a really nice job on this. And that potential 8-day contraction in time will be really important for our modeling of COVID and being able to potentially make decisions sooner. And so I'm really happy with the results, and it's been really a lot of fun. Thanks.
Thank you. Now I'll open up to questions from the audience. Again, if you have a question, just raise your hand and Ming will unmute you. Sure. Well, I'll ask a question. Hey, Ben or someone else, could you elaborate a little bit more on that that third method? Why it was problematic for you? What was the that you were unable to fit the time invariant thing?
Because the time invariant assumption model require you to fit a spinal regression within a given window period, and the given window period has to be turning. This is the first one you have to be turning, and then the spinal regression with different node has to be turning. So once the window period move day by day, and it will result in turning lots of spinal regression model, and then to determine the best node of a spinal regression, and then you can put into the Bayesian nowcasting method. And this is a really computational costed and require you to do a lot of things before you can use the model. And yeah, so this is why we are not choosing to use this one in our final model. Yeah.
So I think what Yonju was trying to mention, elaborate is our approach. I remember was perform a nowcast by running either model for a nowcast for a current date, and we evaluate. So we perform we run the model once for each of the date in our data within the interested range. So that is like 500. That are so there are 539 days as current date, and for each time of nowcast, we supply the time window considered will be different. The length is the same, but like the cases in the time window will be different. And for each time of nowcast, we will need to tune the parameters, like when fitting the spline regression, based on a different information in that 31 days time window. So that will require us to perform each time we'll tune the parameter, and we do that for like 500 times. So that is computationally infeasible for us. Yeah, I hope that explained the.
Yeah, no, great, thank you. Yeah, we need the faster computers for you guys, right? We need the supercomputer time or something. Well, great. Let's see, I think we probably should move on to the next project. Project 4, you're up.
Hi, everyone. Welcome to our presentation. I'm Zihan. My group members are Ning and Yutong. We performed this capstone project in conjunction with Community Health Plan of Washington. And this project is about developing a prediction model on inpatient admissions. Here are some pictures of our team. Our sponsors are David, Caroline, and Mandira. Past studies have shown that healthcare expenditure is usually concentrated on a small proportion of the population. For example, nearly half of the healthcare spending can be attributed to the top 5% healthcare resource users in Ontario, Canada. Similar patterns were observed in other parts of the world. It is also well documented that the US is an outlier among peer countries in terms of healthcare spending. Recent analysis found that the cost of inpatient care is a primary driver of the gap in health expenditures. So it is important to develop a valid risk prediction tool that helps identify population segments that will likely be admitted to the hospital in the near future, so that the care management team in health insurance agencies can provide timely support for high-risk individuals, thus reducing the likelihood of adverse health consequences. Our primary objective is developing such a valid prediction model, with the outcome being inpatient admission in the next 12 months. And our second objective is applying the technique called classification with no discrimination to correct for racial bias embedded in the data, which refers to the substantial difference in incidence rate of inpatient admission comparing different racial groups. The technique ensures impartial results for future classification. Ning will introduce more about the technique later. Our study population consists of Community Health Plan of Washington members from the start of 2018 to the end of 2019, with certain exclusion criteria, including but not limited to pregnancy, end-stage diseases, newborns, and death. Our candidate variables include insurance plan enrollment, medical claim, medical diagnosis, risk level, which is computed based on chronic conditions and healthcare expenditures using internal algorithms, demographic information, social determinants of health and behavioral health, such as smoking disorder, substance abuse, and homelessness. Let's talk a little bit about our modeling. For this project, we would try 3 types of prediction models: penalized logistic regression, gradient boosting trees, and Bayesian addictive regression trees. Penalized logistic regression imposes a penalty for including too many parameters. The coefficients of less constructive predictors are forced to be 0, which encourages a simple, sparse model. It is easy to implement, computationally inexpensive, straightforward to interpret, and it resonates with the prior work performed by our sponsors, which is stepwise logistic regression. However, the drawback is that we think the performance of the model would be less ideal than tree-based models.
So the second one is the gradient boosting trees. It is a supervised learning algorithm which attempt to accurately predict the target variable by combining the estimates of a set of simpler and weaker decision trees. It is a tree-based model that incorporates interactions. It has shown great results in many classification benchmarks, and it is highly customizable. It can be tuned for imbalanced data. However, it is less interpretable in nature and tends to overfit and has a lot of tuning parameters.
The third model is Bayesian additive regression trees, or BART. It is a sum of tree model adopting a Bayesian framework by imposing a prior to regularize the model. It also incorporates interactions because of the tree structure, and it provides prediction confidence intervals as a measure of uncertainty. And the name says it's a regression tree, but it can be modified very easily for classification, and it's very easy to tune because according to the original research paper, that the model performs very well in its default state. The model fitting uses the Bayesian backfitting procedure, which is a highly sophisticated algorithm. So the computation costs a lot, might be very slow, and also it's very uninterpretable in its nature.
Here is an overview of our modeling process. After data extraction and initial data exploration, we randomly split the data set into training set and test set with an 80-20 ratio. Each of us train a class of model on the training set with 10-fold cross-validation approach, which is referred as training stage 1. After that, we implement CND technique on the training set, which Ning will introduce later. and repeat the cross-validation training process, which is referred as training stage 2. The performance of the new optimal model selected from each class is evaluated on the test set. Finally, we select the overall best model based on the F1 score from the training stage 2, which is after CND implementation. During the data exploration process, we realized that the distribution of the binary outcome in patient admission is highly imbalanced. Only about 4% of the study participants are observed with the outcome. Also, we discovered that the majority of the predictors are categorical. Some of them have many categories, which leads to a sparse data matrix with an overwhelmingly high proportion of data being 0. For example, originally we have 60 dummy variables for chronic conditions, but the majority of the data are zeros. Hence, our sponsor helped us grouping them into 20 categories, which reduces the sparseness of the data. We also performed standardization for the numerical features before implementing penalized logistic regression.
So now I'll talk about our primary analysis and its results. So following the modeling procedure previously introduced by Zihan, we trained all the 3 proposed model, and this table shows the prediction result as well as the evaluation metrics for each model. And this evaluation is done on the testing data. So the first row is sensitivity or recall. It's the number of true positives divided by all positives in the data. It is measuring how many admissions are captured by the model. The second row, the positive predictive value or precision, is the number of true positives divided by the predicted positives. And this one is measuring how precise is your prediction. And finally, our metric of choice, F1 score, is an average between the sensitivity and positive predictive value. We use it because we want to put equal weights to true positives and true negatives. And the bottom 2 rows are the confusion matrices. And we can see here the tree-based models performs much better than the GLM, and the overall best model is BART, followed closely by the GBT. Oh, by the way, we did perform feature importance investigations for each of the model. My teammate Yutong will discuss about it later. So now we move on to the secondary objective. And our secondary objective is to correct the bias in the prediction. So the idea is very simple. If your training data is biased, then the model learned based on this biased data will show biased predictions. And in our use case, we need impartial classification results. So we use the CND technique to make the least intrusive modifications to our biased training data set in order to correct for the bias in prediction later. Yeah, so actually before we implement the CND, we did some exploration on the bias in the data. So this chart is a bar plot, shows the event rate in 8 different racial groups. And we see here the rate can be as low as 2.8% in Asians or to as high as 6.6% in the American Indian or Native Alaskan natives. And a chi-square test shows that these incidence rates are not equal. So we move on to implement the CND technique. And this technique is performed after the training stage 1, and I'll tell you why we did it in that time point. So I'll walk through the process of this data massaging. There's a table that will grow as I go through it. So this is done in the training data. So the first column here is the number of observations in each race in the training data. The second column is the proportion of each race in the training population. The third column is the actual number of admissions for each race, again in training data. And here's the key numbers. The expected admission, that's the expected number of admission if each race have the same instance rate. So this is calculated using the total number of admissions multiplied by the proportions. It's like we're distributing this number of admissions across racial groups according to their makeup in the population. And finally, we can take the difference between the actual number and the expected number. And essentially, this difference is the bias in the data. It is also the number of modifications that is needed to correct for the bias. So how do we correct the bias? Firstly, we define our promotion group and the demotion group. So if the difference is negative, that means in that race, there's actually less admissions than expected, and we need to promote people from this race. And we can only promote the people without admission. So in the race with negative difference, the observations without admission will be put into the promotion group. And following the same logic, a race with a positive difference, in that race, the observations with admissions will be put into the demotion group. And remember, this massaging takes place after training stage 1, right? So we already have a prediction result from the stage 1, and we can use that to rank our data within each group. And using that rank, we can promote the observations with the highest rank, and by switching their label from 0 to 1, and we can demote the observations with the lowest rank by switching the label from 1 to 0. That way we are making the least intrusive modifications. So after we do this modification to all 8 racial groups, the modified number of admission will match the expected number. And we can use this now corrected unbiased training data to do the training process over again, and that is referring to the training stage 2. So how does the CND, how did the CND work? We can evaluate the effect of CND in the testing data. So this table, the 4 columns in this table is the same, is calculated the same way as before, but only in the testing data. And we are going to use this expected admissions to evaluate our bias in the prediction. So here, the first column is the expected number. The second column is the prediction in the testing data using the model trained on the biased training data. That is the data before CND. And the third column is the difference between prediction and expectation. The fourth column is the predicted results after the CND. So that's using the model trained on the corrected data. And the last column is the difference between the prediction after CND and the expected value, expected number. So you can see here, this difference where the bias is reduced by a lot. And we also did formal statistics testing that says before the CND, the prediction is biased, and then after CND, this bias it's not significant. So now one might ask questions, if you modify the data, what does that, what's the impact on your training, on your performance, on your model performance? So we use the model from both stage. We use the final model from both stage to evaluate on the testing data. Here's the result. The top half is the result before CND, and the bottom half is after CND. And we do observe a drop in performance, but the decrease is very small. The F1 score is decreased by less than 0.01. So we think CND works very well.
So about the model performance and bias correction, regarding the not ideal F1 score of positives, we think that the main reason is due to imbalances in the inpatient admission. We try to deal with the imbalanced problem through different approaches. For penalized logistic regression, we tried oversampling the positive outcome group and undersampling the negative outcome group. For gradient boosting trees, the scale plus weight parameter within XGBoost control the balance of positive and negative classes. And for BART, we used undersampling for the negative outcome group with different class ratios. Unfortunately, the performance does not have any meaningful improvement after implementing these techniques. And we also attempt rows, SMOT to deal with class imbalance, but did not carry out successfully due to the limited computational resources. However, bias correction was successfully corrected, the racial bias in prediction results, and minimized the loss of prediction power. Now let's see some feature importance. So here are some features selected by penalized logistic regression according to the magnitude of coefficient. So it seems like only one feature stands out, which is the insurance plan of BH service. And features selected by GPT depends on the information gain. Two features shown to be more important than others are age and number of chronic conditions. And for BART, BART selected features by the proportion of inclusion in splits. It seems like there's no specific feature stands out, but overall it seems to agree with GPT results. So in summarize, within some of the common top important features, age, revenue, medical expenses, number of inpatient admissions in previous years, number of chronic conditions are all positively related with future inpatient admission. And for Apple Health Family Plan members, male and membership months are negatively associated. So for the project impact, although the final model performance is not ideal, it has been improved a lot compared to sponsors' prior work using stepwise logistic regression with a restricted study population to CHPW members, including Apple Health members, and only predicting the future 3 months outcome. And with the help of importance plot, we identify subsets of variables that contribute more to the outcome prediction. Those information can guide the future investigation on risk factors for inpatient admission and supports case management teams of CHPW to identify high-risk enrollees. We also established confidence in the CND technique. The racial bias was successfully corrected after applying CND, and the model performance does not affect by the correction significantly. Some of the future directions. So given the large sample size and high diversity of our study population, future statisticians may consider splitting the study population into multiple subgroups based on some certain characteristics, and also identify an optimal prediction model for each subgroup. Subgroup-specific model can possibly improve the prediction accuracy for certain member segments or the entire population. Additionally, CHPW may consider collecting data on other variables that can contribute to the prediction of inpatient admission, such as participants' education level, stress level, and type of application. Besides, imbalanced outcome distribution is still a major obstacle to higher model performance. So if the time and resources allow, it would be worthwhile to try different techniques to handle the imbalanced data set, such as applying rows and SMOD. Finally, try a wider range of statistical methods might also contribute to the boost of prediction accuracy. For example, neural networks might have the potential to outperform the current models, given that they have the ability to implicitly detect complex nonlinear associations and the ability to detect all possible interactions between predictors.
So finally, we want to give special thanks to all the people who helped us along the way in carrying out this project. Thank you. And that's the end of our presentation.
Thank you. And before we move on to questions and answers, I think your sponsor, David, is here. Would you like to say a few words?
Yes, I'd love to. Well, we had a fantastic experience working with Xian, Yutong, and Ning. And in fact, this was our first experience with the Capstone project. And I was so pleased. I hope that we can do this again in the future. You know, this question is important to health plans like ours in order to be able to identify folks ahead of time and potentially help them access outpatient care so they don't end up in the hospital where it's expensive and potentially dangerous for a member to be in the hospital in terms of acquiring other diseases and so forth. So the fact that we were able to work with these students to do some more sophisticated modeling than we had done in the past was fantastic. The work that they all did working with the classification no discrimination model to help us understand that there is little deterioration in performance when we use that model. And the reason why we use that model is because we don't have any proof that there's bias in our data, but these kinds of predictive models that have been used by health plans nationally have received criticism about being biased because they're based on healthcare utilization. And we know that people of color have limited access to the healthcare system relative to white people. So we wanted to proactively build this into the model and appreciate what we were able to learn from this experience. Overall, for me, I was highly impressed with Ning, Yutong, and Xian with the level of organization that you brought to the project. I thought your qualitative research and understanding why we do this project and why it's important to us was great. I thought your statistical plan was well laid out. I thought you all worked impressively well together as a group, and the statistical brain power that you brought to us and all of the findings that you went through are important and valuable to us. So we appreciate the opportunity and all the work that you did.
Thank you. I think we still have a little bit of time, maybe time for one question. So speak up if.
Katie, go ahead and unmute yourself.
I think I kind of missed, like, when you say the data are biased, in what sense are you using bias? Like, usually I think about, someone says the data are biased, I think, well, there's selection bias in there. But I didn't quite grasp the sense in which you were calling the data biased.
So I think the bias is like, ideally we want so regardless of your race, we want you to have the same chance of being predicted to have admission. That's that's our definition of unbiased prediction with respect to race. And the bias is here, like showing this, is the difference instance rate in the training data, in the data. So it's like a kind of philosophical thing. So the data is, the model is honest, it's gonna reflect this difference, but we don't want the result to be this way. So we want to correct for it.
Yeah, Katie, the way I think about it is, and I may not be thinking about it as deeply as I need to, but if historical claims utilization is the main predictor of a hospital admission, and people of certain races and ethnicities have experienced discrimination or limitations in generating utilization in the first place, that's going to lead to a model with some inherent bias in terms of appropriately identifying people who might be susceptible to admission.
Yeah. Thank you. Thank you. Well, given the time, I think we should move on to our last group. So Project 5, you're up.
Hello, everyone. My blood pressure is so high. I'm so ready. Okay. All right. Okay. Okay. We would like to welcome everyone to the final presentation of the day. Medication use and pain score trajectories after pediatric tonsillectomy, a project in collaboration with Seattle Children's. This is our main team. The Capstone team consisted of Yao, Caillou, myself, Min, and Ivy. Our main point of contact was Dr. Dwight Berry, Principal Data Scientist at Seattle Children's. We also consulted with Sanjay Parikh, MD, who is Associate Surgeon-in-Chief and Medical Director at the Bellevue Clinic and Surgery Center at Seattle Children's, And we also want to acknowledge our professors, Patrick and Lloyd, for helping guide us into this new task. So what is pediatric tonsillectomy? This is a surgery to remove the tonsils in children. On the image at the left, we can see it shows where the tonsils can be found in the child. The typical recovery time is 7 to 14 days. Common symptoms include bad breath, fever, and pain. Medications often consist of alternating use of acetaminophen and ibuprofen. Clinicians can also prescribe oxycodone for moderate to severe breakthrough pain. A special consideration about this procedure is that pain may increase on days 5 to 7 after surgery. This is when the scabs in the throat begin to fall off. Before we jump into our study, we want to provide some background context. Nearly 9,000 children and adolescents died between 1999 and 2016 from opioid poisoning. During this time, the mortality rate increased 268%. In an article on the right, it details Seattle Children's scientific process in developing an opioid-free intervention. And this is a quote from the article itself. The results of these interventions were so promising that by January 2019, we decided to remove opioids from all standardized intraoperative anesthesia protocols, end quote. At the same time, tonsillectomy is one of the most common surgeries performed at the hospital, so that they also developed a tool for patients and parents to use at home to help track pain and medication. The tool is called POP Care. POP standing for post-op pain. On the right, you can see a screen what it looks like to enter this app for the very first time. Using the app, patients and the parents can assess pain using the FACES Pain Scale Revised, FPSR for short, for children over the ages of 3. The scale goes from 0 to 10, even numbers only. The leftmost face shows no pain, while the rightmost face shows very much pain. Fun fact, this is similar, keyword being similar, to a linear interval scale. And on the right is what it looks like to input pain into the app. Another feature of users is they can also record medications on the app. The 3 medications they can record is acetaminophen, ibuprofen, and oxycodone. The left shows a picture of how users can input the medication, and then on the right is a calendar feature helping users track medication. So we will be primarily working with app data. This led us to form 4 main goals. Goal number 1 was to describe the app usage in general, how many people use the app and for how long. Next, we want to characterize pain score trajectories. After, we want to quantify the difference in oxycodone usage rates after the transition to opioid-free surgery. And finally, we want to explore the impact of oxycodone on next day pain. So to begin, this is kind of us diagnosing the app for Seattle Children's. We want to explore the data and give a brief overview of it. One of the first insights we saw was that there was a steady influx of new users. To show that, we have a line plot where on the x-axis, we have the year then month, and on the y-axis, we have the count of new users gained per month. Looking at this plot, it may look like there's a downward trend, but if we separate it by, at that point, 2020 April, when the majority of COVID lockdown procedures began in King County, we can see that before that date, there's roughly, I would say, 15 to 20 new users per month, and after that date, there was 5 to 10, so there was a consistent amount of users coming to use the app, and in total, there was 584 users. However, we also found that most users did not record for long. To demonstrate that point, we have a bar plot where on the x-axis, we have the days after surgery, 0 standing for the day of the surgery, and then something like 5 standing for 5 days after surgery. The y-axis is the number of active users. We can see from day to day, there's a decline in the number of users, with the sharpest drop-off being from day 0 to day 1. We found that there was an average number of 4 days recorded per user with standard deviation of 3 days, my bad. Next, we found that there are similar pain distributions, but a slight shift on days 5 and 6. To show this, we built a ridge plot. In this case, the ridge plot is essentially multiple bar plots stacked on top of each other. On the y-axis, we have our 0 to 10 pain scale, and on the x-axis, and on the y-axis, we have the days after surgery. We can see that for every day, the most common value was 2, followed by 4, then maybe 0 or 6. We can see on days 5 to 6, there seems to be an increased proportion of the higher pain values, which matches our background intuition that on days 5 to 7, the scabs may be falling off. And we found that there's an average number of 14 pain scores recorded per user. Then finally, we found that medication users matched their expectations. Again, we have my favorite plot, the bar plot. On the x-axis, we have the days after surgery, and on the y-axis, we have the proportion. Recall that users were expected to alternate between the acetaminophen and ibuprofen. And looking at the plot, we can see that they match up roughly. And the lowest proportion was oxycodone. We found that there's an average number of 16 medications recorded per user, a standard deviation of 20. So just to wrap it up kind of quickly, the main insights from our EDA was that there was a steady influx of new users, but most users did not record for long, and that medication usage and pain distributions were not surprising. So the app itself as a tool was useful to some patients, but now we're going to move on to our more methods-based analysis.
So for M1, we are trying to characterizing the pain trajectories. So we are using data from 349 participants who at least have 3 pain score measurements. The reason why we have such limitation is first, GMM modeling requires that. Second is we believe the participants need to have at least 3 pain score measurements to actually have a pain trajectory that is making us to become possible to see how linear trend of pain score over time changes. And we are using gross mixture model as a latent class analysis in this analysis because latent gross mixture model is a method of identifying differences in longitudinal change among unobserved groups. The reason why we are using such analysis is because we believe there are so much potential confounders that may affect the participant's pain score, but the app is not collecting such information. For example, the app is not collecting the participant's age, sex, and race because of the privacy reason. So we don't have any information about it. Then that's why we are using latent class analysis trying to address for those confounders. And we will use linear spline model as a basic regression model. Because using gross mixture model analysis needs us to pre-specify the number of groups. So we are fitting different GMM with different number of groups from 1 to 4. And we will choose a model with lowest Bayesian information criteria and the largest log likelihood. We will set the linear spline model node on day 1, day 5, and day 7. The reason why we set this node on those days is because of a previous research study suggesting that the participants may experience pain increasing from day 5 to day 7. So we may expect there is a difference in the trend of pain score over time on day 5 and day 7. So we are setting node on those days. And we will use random intercept and random slope to address for the individual's variance. So here is the overall pain trajectory for the 349 participants. And we can see the users are decreasing, the number of users is decreasing over time. So in many ways, the pain trajectory is more accurate at the earlier time compared to the later time. And we can see the overall pain trajectory is showing the pattern that the participants are experiencing increasing pain from day 0 to day 6 and decreasing after day 6. So here is the results from the GMM models. It seems like the GMM models with 4 classes are giving the largest log likelihood and smallest BIC. And most of the participants, about 62% of them belongs to group number 3, which have similar shape than the overall pain trajectory we just saw. So the class number 3 participants are expected to have a pain trajectory of pain scores that is decreasing from day 0 to day 1 and increase from day 1 to day 5 and decreasing after that. And class number 1 and class number 4 are having similar shape too by increasing the pain scores and decreasing after that. But the change point of class 1 is on day 5, but the change point of class 4 is on day 7. The class number 3 the class number 2 is kind of different than the rest of the 3 classes. The participants of class number 2 are expected to have a decreased pain score after day 1. Overall, these 4 pain trajectories are matching what we were expected.
Okay, so in January 2019, Seattle Children's Hospital removed opioids from their pediatric tonsillectomy surgery. And there is an interest in investigating if that affected oxycodone usage after the surgery outside the hospital. So our aim is to investigate the opioid usage difference before and after January 1st, 2019. So for this aim, we only consider 550 patients who have recorded at least one medication. The reason of doing so is that zero medication would give too much weight to the zero opioid usage. And 65% of the patients took surgery after January 1st, 2019. So the data is kind of balanced. The 4 figures on the right are the density plots for each medication usage during their recorded time interval. The red one is before January 1st, 2019, and the blue one is after the January 1st, 2019. And we are interested in the second figure, which is the density plot of oxycodone usage. The x-axis is the opioid usage count, and the y-axis is the density. And we observed that the density of large oxycodone usage, for example, around 20 and 30 is higher after January 1st, 2019. And here is the plot for the density of the oxycodone usage rate. And the rate is the oxycodone usage per day. And for this plot, we observed that the density for rate 0 and the rate which is larger than 3 is slightly higher after January 1st, 2019. And based on our background knowledge about the count data and considering the over-dispersion issue, we fit a log linear model using negative binomial regression with oxycodone usage as the response, whether the surgery happened after January 1st, 2019 as the predictor of interest, and the log of the maximum number of days entered in the model as an offset. And the result is shown in the table below. And we estimated that the oxycodone rate ratio, which is the ratio between oxycodone usage per day after January 1st and 2019 and before, is 3.45, which means that the oxycodone usage rate after January 1st, 2019 is higher than before. And this difference is significant.
And for our M3, we want to estimate the effect of oxycodone on next day pain over the 7 days after surgery. So we proposed a linear transition model with generalized estimating equation, where we use today's pain as the response, previous day's pain, and the total number of oxycodone have taken in the previous day, and time have passed since the surgery as the predictors. Meanwhile, we use the independent working correlation matrix to account for the individual correlation. So about the missing pattern, so for the PAN score, we observe a significant amount of missingness from the first plot. We can see that a clear increased trend by day, and at day 7, there are around 79% of missingness. And from the second plot, we can see that the majority of users drop out from using the app once they left. And for the oxycodone, we assume for the users who did not report oxycodone, they did not take oxycodone on that day. So there is no missingness on oxycodone. And to account for the missingness, we proposed most recent case analysis method. And that means, which means if a user did not record their pain on the previous day, they will look back to the most recent record and use that as the previous day's pain for modeling purpose. And by using the most recent case analysis, the number of users increases from 278 to 291. And the number of days of using the app are approximately the same, which is around 4. And the PAN score, the average PAN score during the days the users use the app are around 3.8. From the available case analysis and the most recent case analysis, we found that oxycodone is previous oxycodone is significantly associated with the pain change. However, the direction of the effect are different. For the available case analysis, we found that average pain increased following every increased by 0.03 following every dose of oxycodone which had taken in the previous day. However, from the most recent case analysis, we found that the average pain decreased by 0.03 following every dose of oxycodone which had taken previously. Although the magnitude are small, but it is a surprising finding. Yeah, a brief recap. We found that from the exploratory data analysis, we found that POP care is a useful tool for some patients. And from our M1, we found that there are possible 3 to 4 different classes of pain trajectories for our population of interest. And from M2, we found that opioid usage rate is higher after January 1st, 2019. And from M3, we found that it is inconclusive about the relationship between the number of oxycodone and next day pain.
So I will introduce some limitations of our analysis. For the upper plots, we can see that about 55 people are only recording the pain score on day 0. This means that the pattern plot is only for M1 data set. Then we can see that actually people are stopped using app after day 3 or day 4, and they won't go back. Most of the participants won't go back after they stop using the app based on the missing pattern plots. And we can see that there is only a minor differences between 3 class models and 4 class models in BIC and log likelihood. So for future research studies who want to save more storage or want to use the use the model with with less classes, can use the 3 class models. The difference is very small. Yeah.
Yeah, and in addition to the significant amount of missing data, we also think the data are missing not at random. It can be there are several reasons. The first one is it's possible for the users to stop using the app once they know what suggestions the app will give to them. The second one is if they feel not very painful, they will just stop using. The third reason is if the patient feel very painful, they will just take the oxycodone. So for the future study, it might be worth to investigate other better methods to accounting for this large amount of missingness and this missing not at random situation.
Yeah, and just to recap, the insights are kind of only applicable to our app user. So for example, one limitation is the app is only in English. So maybe only patients and parents who are comfortable with an English-only app would use the app. For future app research, we were considering what's the impact of including day 0, the day of the surgery, into our analysis. That did affect a lot of our missing data. Another thing we want to consider is refining the wording in the survey. For example, how users were asked, how bad is your pain? Maybe a better way to ask pain is because people could, over the course of a day, someone could have entered 1 pain score while someone else could have entered multiple pain scores, maybe multiple zeros, influencing the result. So maybe a better question could be worded as, if you experience pain for at least 10 minutes, what was the maximum amount of pain you experienced that day? And then another way to collect information while still respecting privacy would be something like an exit survey, which would allow analysts to maybe make better assumptions about the missing data. But
yeah, that's all for our presentation, and thank you for your attention. We're open to any questions.
Let's see, I think your sponsor here, Dwight, is here. So Dwight, would you like to say a few words?
Stop sharing.
Yes, thank you. I was so impressed by the work that this team did. And even when I didn't understand some of it. But yeah, we had a rare opportunity at Seattle Children's to evaluate what happens after surgery. We know what happens in the surgery room down to the millisecond, really. But once our patients go home, we don't really know what happens. And this was a rare opportunity to start finding that information out. And like any good statistical study, we're left with as many questions as we started with, but things now that we can move ahead and try to figure out surprising results, like why are parents using more opioids after we stopped using them? We don't know. But I really appreciate all of the effort of this team, as well as the Capstone program, and thank you very much for your time and your assistance and your really wonderful work.
Thank you. Now I'll open up to the audience if you have questions for the students. Well, I have a question for you guys. If you had to add one question to the app, what would that one question be?
Oh, that's a good one. So, okay, if we had to add one question. Oh, sorry, does anyone want to take the NU team member? No? Okay, so I guess the main problem when we were developing our SAP in fall quarter was that we had many confounders. What we did in the beginning of fall quarter was we sorted through what was important. Like, for example, one of the very first things we tackled was, did adenoidectomy, another type, if you go back to the, oh, can I share screen again? Sorry, okay, I'm gonna share screen again. So something, if the keen eye might have noticed, was that there was also, adenoids was also like covered in this slide. But after talking to the clinician, they were like, oh, adenoidectomy, tonsillectomy, very similar. So I think going back to all of it, I think the question would be age, because the range was from 3 to 19. From background research, the average age for the tonsillectomy performed at the outpatient center was 6 years of age. So I think if we can have age, I think that would help a lot. Other than that, I think we would want clarification of the questions already on the app. There also was a survey feature that we didn't really cover, but some clarification of those part. But yeah, I think age was the one thing we would love to ask, because I think that would help a lot. Yeah.
Anyone else have a question they would like to ask? Well, if not, it's getting kind of late here, so I'd like to kind of add a few closing remarks. First, I want to thank all the students for sharing your capstone projects with us today. I've been really impressed by the variety of problems that you've stretched yourselves in your capstone project to solve, and really delighted by what you accomplished. Again, thank you to our sponsors for making this opportunity or giving this opportunity to our students. It's just been invaluable for them. I also want to thank the audience for listening in today. I know it's been a long 2 hours, but hopefully you enjoyed the variety of projects and hearing from 18 different students. And then on a final note, I want to add my perspective about today's presentation, because to me, they just represent the tip of the iceberg of the students' experiences. I have particularly enjoyed discussing with the students over the last several months about the problems that arose in their projects, and actually hearing about their interactions they've had with their sponsors to solve these solutions, to solve the problems that they came about. And just to hear about the aha moments or the low moments of like, oh crap, we can't get this to work. What are we going to do? Oh my gosh, the data is so large. What's going to happen? So to me, what's been most rewarding is not their final presentations today, though I got to admit, I thought they're all great. But what has been most rewarding to kind of observe your journey that you have made to get here today. And thank you for sharing that with me. I can go on with each of you, personal experience, like, oh yeah, I knew that exact thing. Oh, wow. And that's going to stick with you and save you being valuable in your future careers. So again, thank you for presenting your results today, and I wish you the best for your future. Okay.